Hello, my name is Dr. Elizabeth Woodhams. I am the Medical Director of Family Planning at Boston Medical Center, and today I am here as a medical consultant for the PIC program, and we're going to be talking about postpartum contraception and lactation. The way that this module and training program is set up is we have a 5-section module. You can complete each section in order at your own pace. They will start and stop, and you can just go through them as you need to. We have a disclaimer here that we recognize that every person who delivers a baby is not necessarily a woman and doesn't identify as a woman. And so while I make every effort to use inclusive language, when the research was grounded in cisgendered women, we'll use the word woman. And then we have resources associated with each section, and we encourage you to check those out. So giving birth is often a life-changing experience for a patient and their family, and it's easy to get swept up in the excitement of all the new changes early on. For many patients, another pregnancy in the near future is not part of their plans. So our learning objectives for today will be to discuss the need for immediate postpartum initiation of contraception. We'll discuss what those options are for postpartum patients. We can review the evidence for hormonal contraception's impact on lactation outcomes, and then we'll discuss the roles of nurses and clinicians in supporting our patients' contraception plans. So part 1 will describe the need for immediate postpartum initiation of contraception. Why is talking about contraception during the postpartum period so important? It comes down to the challenge of preventing unwanted pregnancies that happen quickly after delivery or short interval pregnancy. Pregnancies conceived within 18 months of delivery are called short interval pregnancies. Some places call them rapid repeat pregnancies or close interval pregnancies. We care about these pregnancy intervals because of the associated outcomes impacting families and communities. Consecutive pregnancies within 12 months between delivery and conception are more likely to experience adverse health outcomes, and infants born from short interval pregnancies are at higher risk of preterm delivery, low birth weight, and small for gestational age. One of the challenges in preventing short interval pregnancy is that people are at risk of pregnancy when they don't realize that they're at risk of pregnancy. The first 6 months after delivery is often considered safe. Patients and providers may perceive themselves to be at low risk of pregnancy because of some inaccurate physiological beliefs about when fertility returns, or some false narratives about new parents being less sexually active after a new baby. In reality, if a patient and a new parent is not exclusively breastfeeding, they can ovulate as soon as 25 days after delivery. As many as 50% of people will have sex before their 6-week postpartum visit, which means that postponing the conversation about birth control until that postpartum visit isn't sufficient for many, maybe even most people's needs. Beyond that, many patients aren't really able to attend their postpartum visit for a variety of reasons. So if that's the only opportunity you provide to implement a method or to talk about contraception, you're going to miss the chance. There are numerous barriers for people to get the contraceptive method that they want after delivery. There's a massive problem with 50% of patients who request a postpartum tubal ligation not being able to access it, generally for systems reasons. When there's a category 2 tracing on the floor that everybody's watching, we're really reluctant to proceed with what's considered an elective case. And when is there not a category 2 tracing on the floor? Nearly half of people who request a tubal will be denied this tubal. And of the 50% of people who are denied the tubal, they'll become pregnant within a year. And we have very low show rate for postpartum visits. About 10 to 40% of patients don't come back nationally. And that show rate is particularly low for low-income women. Childcare, transportation, communication, all of these things can obstruct your ability to access the postpartum visit that you may want to have. And then LARC, or long-acting reversible contraceptive methods, is not available. A lot of places have 2-visit protocols. The insurance changes 6 weeks out. It's really, really common to not be able to access these contraceptive methods, and up to 75% of patients who request the LARC do not actually receive it. So the immediate postpartum period, right after a person delivers, when they're still in the hospital, is a particularly ideal time to really think about this. The timing couldn't be better. The clinician is often available for counseling and for provision for starting some of these methods. Most patients will remain insured through this visit, so you don't have to worry about the insurance issues. Birth spacing is desired at this point. About 80% of people wish to have 2 years between their kids. And then a review found that patients who receive contraceptive counseling have increased rates of contraceptive use and fewer unplanned pregnancies. So we know that contraception counseling works. Providing postpartum contraception during the COVID pandemic, especially important as many patients have their 6-week postpartum visit turned into a telemed visit. And so this may be the last opportunity for us to be able to see patients in person and start methods that might require an in person visit.